Okay, thank you, Dr. Abrahman. Let us move to the next case. The next case is going to be presented by Dr. Haitham Amin, our great colleague. It's regarding guideliner assisted removal of undeflatable stent balloon. As all of you know, Dr. Haitham Amin is a consultant cardiologist, head of cardiology department in Mohammed bin Khalifa Cardiac Center in the Kingdom of Bahrain. I would like to welcome him to our meeting here today and to start the second case of our session.
It gives me a great pleasure to be here today to present this challenging case presenting in acute coronary syndromes. It's called, the title of my talk is Guideliner Assisted Removal of an Undeflatable Stent Balloon. This is a 29-year-old gentleman who is a poorly controlled diabetic, a dyslipidemic. He presented with a 4-day history of intermittent chest pain that worsened. He had pulmonary congestion on examination. His ECG showed right bundle branch block, ST segment elevation in AVR, and second-degree heart block. His troponins were positive, and he had ongoing chest pain. And for this, he had to be taken for urgent angiography. These are still images of his angiogram. This showed tight proximal and mid-LAD stenosis, as well as a tight proximal circumflex stenosis, which I will show the cines to right now. So this is the apicaudal view. We had to put in a pacemaker because the gentleman was in 2-to-1 heart block, and you can appreciate the extent of this gentleman's disease both in the proximal and mid-LAD, as well as in the proximal circumflex. This is a spider view showing you the hazy proximal LAD, which is likely the culprit for this man's presentation, and as well as the circumflex disease. This is the epicranial view showing you the extent of the disease and how small and diffusely diseased this LAD is in such a young man who's only 29, but has really significant diffuse distal LAD disease. So the plan was to go through a femoral approach. We went through a right femoral artery access. We had to put in a femoral vein to place in the temporary pacemaker. We went with the 6 French EBU 3.5 guide. I wired both the LAD and diagonal because there was a sizable diagonal present, even though it was small. We pre-dilated with the 2x20 Minitrek, and then we stented the proximal and mid LAD starting from the os with a long 2.5 by 48 biomime drug-eluting stent. We inflated the stent for 30 seconds up to 10 atmospheres, and then tried to deflate the balloon. So this is a cine of the balloon being up, and here we had actually gone down on the inflator, and the balloon remained up. So the stent balloon did not deflate. I tried several attempts to check the inflator with several negative aspirations without any benefit. We changed to a 50 cc syringe to try and aspirate without benefit. We reattached a new inflator, thinking maybe the first one had a problem. That actually didn't work. We then post-dilated the stent up to 16 atmospheres, trying to either rupture rupture the balloon, and then to be able to remove it, but we failed to actually do that. And then we tried to pull out the stent forcefully, and that also failed. Lastly, we tried to use the distal end of a pilot 200 wire to try and perforate the stent balloon without success. So all these attempts failed. And then we thought of using a guideliner. So a guideliner assisted removal of this undeflatable stent balloon. So what we did was, because we were going to insert the guideliner, we had to remove the second wire, which was a jail diagonal wire. We then cut the distal hub of the stent catheter. Once the distal hub was cut and the hub was removed, as well as the inflator, we inserted the 6 French guideliner over the stent catheter and the guide wire, which was down the LAD, and maneuvered the guideliner all the way up to the LAD stent and to the origin of the undeflated balloon. We pushed the guideliner into the LAD stent. As the guide was stabilized, and the stent catheter was actually pulled back. And we tried to basically use the guideliner as a support inside the balloon and stabilize the guide and pulled the stent catheter out, basically milking the contrast out of the stent balloon with successful removal. And I'll show you this. This is just still images. On the left, you actually see the first arrow shows you the tip of the guideliner as it just entered into the stent, and the proximal stent marker, which you see just before that. And then, as we were able to forcefully pull the balloon out, you actually see that the guideliner remained in place while the proximal stent marker was pulled out, and we were able to successfully remove this really long balloon. And this is just a cine of us showing you where the guideliner is and where the proximal stent marker of the balloon is. And in the second view here, this is a fluorosave. You see we're actually pulling on the balloon and with the guideliner in place, and this long balloon is finally getting freed as we milk the contrast out of it. Let me see if I can just play this again for you. So this is the proximal balloon marker. That's the guideliner. This is the stent. We're keeping the guideliner in place, stabilizing the guide, and pulling out the balloon, and we were able to actually do that. Let's just run one last time. So the only way to actually get the guideliner there is to cut the distal hub and then just be able to place the guideliner on the stent catheter and wire and bring it all the way up to the entrapped balloon. Now, because we had lots of maneuvering of the guide catheter, there was some ostial deformation of the stent, which required reballooning, restenting, and there was an outflow dissection that required implantation of another 2.25 by 15 DES at the outflow of the stent. And then we were finally able to finish by stenting the circumflex, and this is the final result showing you both the LAD and the circumflex. I'll just show you the cines here, showing you the final result of both the LAD stent as well as the proximal circumflex stent. This is a spider view showing both deployed stents, LAD, 2 stents, and the proximal circumflex. And this is the epicranial, so showing a reasonable result here given the circumstances. So the total time the stent balloon was inflated was 14 minutes. It seemed a lot longer than that during the procedure. And luckily, the patient was hemodynamically stable during all this time without any hypotension or arrhythmias. So in conclusion, the undeflatable stent balloon is an uncommon yet dreaded PCI complication. Several tips and tricks have been described before in the literature. Our case demonstrates how a guideliner can be used to assist removal of the undeflatable stent balloon, with the guideliner delivered over the stent catheter after cutting the distal hub of the stent catheter. So I hope this case was enlightening. I'm honored and pleasured to be here with you today, and hope that this case may give you a solution should, God forbid, you see a similar case in the future. Thank you again, and I wish you all the best in your meeting.
Great case, Dr. Haitham. I'm really astonished by the innovative way, I would say, in like retrieving the balloon, and probably this is it should be like a reported case. I don't have any question, but I think Dr. Abdurrahman has a question to Dr. Haitham. So go ahead, Dr. Abdurrahman.
Assalamu alaikum, Dr. Haitham. I have 2 questions for you. Question number 1, in cases like this before, I actually faced undeflatable balloon, but I managed to pull it all the way to the brachial artery. And then under fluoro, I just used a direct needle and I ruptured it. It's proposed also you could use a CTO wire and trying to go and puncture the balloon. Was that something that you could consider? The question number 2, in order for you to load the guideliners into to milk that balloon, you have to actually load it on the shaft of the balloon itself. So it means that the Guideliner from the beginning, you had to load it on the balloon and the wires. How did you do that? Did you cut the distal, the proximal end that you have outside the patient that's related to the balloon? Or how did you do it? Because it's not easy to load the Guideliner on that. I just want to know your technique again.
So I'll just answer the second question, Dr. Abdurrahman. So what we had to do was, the stent, the catheter at the end, there is the hub to which we connect the interflator. That hub you would need to cut with the scissors. So we went ahead and we cut that distal end of the hub out. So we removed that, which then leaves you the hypotube and the LED wire. And then we placed both the LED wire and the distal stent catheter on top. The Guideliner went on top of these, and we were able to feed this all the way down to the left main stent. So you have to cut the distal hub. Without that, it's the same technique that you use for an entrapped rotational atherectomy burr. What you can do, and this was shown by our colleagues, Dr. Khalid from Jeddah, you basically cut the distal end of it's the same concept, rotablator, okay, where it connects to where the shaft is connected to the console, remove the plastic hypotube, and then insert the Guideliner, and you can use the same technique to actually remove an entrapped burr. So, or if you have a 4 French guide, if you don't have a Guideliner and it can fit, you can actually do that. So you have to cut the distal hub to be able to actually get your Guideliner down. The distal hub of the stent catheter.
And your Guideliner was 6 French.
It was 6 French. It was 6 French.
And then there was no difficulty passing both together at that time.
No.
Thank you.
I know this is a great case, and there will be like a lot of discussion. Dr. Muntasir, you have any question?
Yeah, actually, first of all, just to thank Dr. Amin for this great job. And I think day by day for us in the intervention, we realize that the good interventionist is the one who is ready for such complications. So well done, Dr. Amin. My question, whether in such diffuse and long lesions, would you consider like multiple shorter stents than such a long stent, which is more likely, let's say, to be to have such complication? What do you think about this point?
Well, I mean, if you could get away by using one and now we even have up to 60 millimeter stents, from the same company that actually, made the Biomine. And even Zions has 48 millimeter stent. So if you can get away, I think it'd be better to actually just do it with one, overlapping segments, even though if you really post-dilate them well, it should not be a problem. But if you can get away with one, I do, and it's probably maybe cheaper. I don't feel strongly that, for such diffuse disease, it has to be 2 stents. So if one will do the job, I'll use one.
Okay.